primary closure. Okay, so without further ado, let's welcome Dr. Zhang.
Okay, do I have sound? I don't hear the sound. Hello, can you hear me?
Yes, we can.
Very good, very good. I'm so happy to be with all of you. I know this is your lunch break and you just finished the surgery already. But this is very interesting. I would want to present my technique to you and then encourage you to participate even during when I'm talking. If you have a question, feel free to ask. We'll make it a group affair, a chat affair rather than just me doing strict lecture. So I would love for you to raise your hand, send questions, whatever you want to do. Okay, now, did Dr. Shui want to show me a case that you did two or three days ago? You want me to start with that? Or do you want to bring it up later?
Hello? What's that?
Okay.
One doctor trying to bring that. So the case on the PDS is bring down later.
Oh yeah, bring it on later. Bring it on later.
Okay, that's fine.
Here. Yeah.
Okay, so later. All right, so I'll start with my introductory talk, and then we'll talk about more interesting things. All right, now let's go ahead and play this video for you to start. Go ahead. Is there sound?
Introducing Chow Pinhole Gum Rejuvenation's pinhole surgical technique. Before, conventional gum grafting required cutting tissue from the roof of the mouth. The gum is then cut over the area of the recession and lifted. The tissue from the palate is placed over the recessions. Once complete, sutures hold the graft in place during healing. Now, with the new revolutionary Chow Pinhole Gum Rejuvenation, gum recession is corrected without cutting or stitches. This new process begins with the tiny entry point that is made in the gum. Then, a special dental instrument is placed through the pinhole to free the gums with gentle movements. Once free, the gums are guided down into a healthy position. When the recessed gums are corrected, tiny collagen strips are placed inside to help stabilize the gums. Incredibly, the pinhole heals rather quickly and often overnight. When complete, the receding gums are corrected with a minimally invasive treatment that is quick, easy, and instantly pleasing.
Okay, I thought I start off with something that everybody
Introducing
has already seen. So let's go ahead and start with my presentation. Just one very quick reference to the fact that gingival recession is very prevalent. We see it in our practices all the time, a lot, on a daily basis, I'm sure, if you're like me at all. So far, the answer until pinhole came around was grafting techniques, and pinhole then offer a different kind of approach that does not require scalpels or sutures. So, but I want to say, as the fundamental question is, why is treatment of gum recession necessary? And our position is that it is a clinical necessity. Class 5 fillings do not address the problem of gingival permeability. In other words, when the gingiva is not attached, there's a permeability problem with bacterial and toxins infiltrating the gingival apparatus. So, and that leads to further bone loss and further gingival recession. So, and fillings, restorative procedures, and crowns don't stop recession. That's something you know about, right? And I've done crowns where I've put it at the gingival margin, and I didn't have enough attached tissue. And then after a while, the patient comes back, I've got a exposed root. So I've done many crowns over because of that. So now with pinhole, you can actually correct that before you do the crown, or as you do the crown. All right, so now we came up with a no scalpel, no suture technique, and that the benefits are what? Significantly reduce patient discomfort, at least in my hands. We don't need to harvest tissue from another part of the body, another part of the mouth, generally the palate, and it's definitely shorter. We can do 1 or 2 teeth in the 15, 20 minutes. We can do a full arch. Upper full arch, maybe 10, 12 teeth in about an hour and a half, the most. Once you're over the learning curve. So that's something that is the unique advantage of pinhole. You see an arch with multiple sites, think pinhole, because that's about the quickest, the easiest, and the least invasive treatment you can offer the patient who has multiple sites on a single arch. And of course, you can do even double arches. And you have immediate cosmetic improvement. In other words, you do the pinhole, there are no sutures. So the gums have magically come down to the patient, and you can show a dramatic improvement cosmetically without any evidence of the typical signs of surgery, which is sutures. And we are very rapid healing because we're not cutting anything. And because I'll draw on that even more, because we use a full thickness flap. We don't cut the flap into half, and we just elevate the entire flap from the cortical plate, and then we don't have the problems with bleeding and pain that goes with split thickness flaps. Okay, so it's just to give you some examples of what pinhole can do. You have a case started, look at your left side of the screen. Immediately after, you see 5 pinholes, and then you see the overcorrection. You see that the gingival line, even though it's highly retracted, we're using a retractor to pull the lips up, so you can see the gum line is down to the contact point. So we reduce it's about 30%, almost 50% of the crown covered, more so in the back. And then you see the 1 week, you see the 6 weeks, and then you see the 1 year. So how do it's not turning. Can you play it? No, wait a minute. I want to show that one. Does this go across? Okay, this is the before, and this is the after. All right. We scan every case. So these are the instruments that are specially designed to go through the pinholes and do the full thickness flap elevation these are designed for. So special instruments. There's nothing that's designed specifically for this technique, and these are the only instruments that are designed for that purpose. So let me play this for you. So this is a person. He was in a hurry, an actor. What happened? And he wanted something done real quickly. And he has a commercial he had to do. So he literally begged us to do it. So I fit him between patients. And I did this whole procedure in 8 minutes. So this is a 1 minute rendition of the 8-minute procedure. So I did a lot of shortcuts, of course. This is not what I'm going to teach you to do, but basically we prepped the root surface, put a pinhole here, use our instrument, special instruments to elevate the flap. The tissue, the flap is elevated completely from the bone. There's no tissue left on the bone. And we basically elevate the tissue mesially and distally enough so that the tissue is so released, so loose that it comes down and way over the CEJ, and then we stabilize it with the collagen. And that's it. So it could be very quick and easy on the patient and easy on the doctor because you don't have to suture. Well, so this is the before. This is the before, this is the after. The before was 2014, the after is 2019. See, the cuspid is actually now shorter than the lateral. But he was very happy. And this is a 5-year case. So that's what I mean. Full arch cases are so dramatically, and it's much easier. The pinhole basically uses the principle of releasing the tissue from the bone sideways, laterally and apically, and of course using special instruments to elevate the papilla. So release is behind everything we do. If we do one tooth, we have to release about a quadrant. So much easier for our technique, pinhole technique, to actually do a full arch. This full arch upper, I did it in about an hour. Lower, about an hour and a half. So we did it in one session. And this is done. This is a 5-year result. So just to give you so this is that patient that you just saw. This is just kind of a snippet of how it was done. So we do prep the roots. We want clean dentin. We want dentinal tubules which are uncluttered. We remove all the restorations. Nothing left behind. So you wonder, is the tissue going to cover that? Yes. You see how deep the second bicuspid is? I told him he might need a root canal. Fortunately, he didn't. So it doesn't matter how deep it is, the tissue will fill in. We're not afraid of creating concavities on the roots. The narrower the diameter, the more the void, the more tissue fills in. It's counterintuitive, but that's how it works. Let's speed up a little bit. So now before we actually start the incisions, we clean it up with EDTA. Make sure all the dental tubules are not clogged, and then we sterilize the field with chlorhexidine. We put a pinhole between the lateral and the cuspid. The first pinhole, you see the instrument go in, it goes to the bone. At a right angle to the bone, the instrument releases, separates the tissue from the bone, and then once it's released, then we go to the next, go further distal, put another pinhole over the second bicuspid. We use the instruments and go further back, releases some more. We're not going to be able to release the cuspid completely unless we release all the tissues around the molar. So it's a matter of releasing laterally and of course apically and be able to then elevate the papilla. So now I am elevating the papilla with a special papilla elevator instrument, has a special curvature on it and blade angle on it so that the papilla can be brought down past the CEJ, way past CEJ. We try to overcorrect it so that when healing takes place, we'll get the maximum coverage that the biology will allow. So this is then repeated as we go after we've gone to the second molar. Then we go forward, go mesially, and elevate the rest of the flap. So you see, nowhere do we cut. We basically move the curtain of tissue from the bone. release it from the bone, and let it basically drop. We make it easy for the curtain of tissue to drop by releasing apically, laterally, and release the what's holding it up, the crucial part of the tooth, and that is the papilla and the facial gingiva. And we'll keep on making pinholes and going distal. And so we progress. This is repetitious. Basically, we loosen up the tissue, tooth by tooth, apically, mesiodistally. Hydrate a lot. As the tissue is loosened up, you can see how basically it just kind of drops down. Even though the CEJ is way coronal because of the restoration. So we don't use the artificially made CEJ. We'll use the clinical CEJ, but even then we see a lot of improvement over time. So we're going to move away from this now because it's basically repetitive. And then we put collagen underneath the do we have a collagen? We show collagen? No. So we put collagen in it, and then we're done. So this is what we get from the operation that you just saw. You see how, look at the second bicuspid. You see how gingiva filled in that void? We did have put a filling in there later. Overcorrection allows the body to give us the best positioning as far as the gum line. But we tell the patient that the real purpose of the procedure is to improve the seal, is to create a wider zone of attached gingiva. That's our goal. And the body and patient compliance decides where exactly the gum line will go, even though we're pretty confident that the gum line will go to the maximum as far as the coronal positioning is concerned. But we put the responsibility, the final results of the positioning of the gum line on the biology in the area, the amount of bone, the amount of how the tissue is, how the patient complies with our instructions. So emphasizing, when we do pinhole, we overcorrect. We bring it way, way down, and then let the body decide where it's going to finally rest the gum line. You notice the upper left 13 area, that's actually a primary molar that never exfoliated. So even with that tooth, that way it is, we still 7 weeks later have coverage. Okay, so I want to present to you some basic research work that was published. The first article that was published was the most difficult, and it was a 33-month study of 43 patients at my office with 121 sites. 85 sites were class 1 or class 2. In other words, class 1, class 2 sites are those sites that doesn't have dark triangles. It's a healthy papilla. Class 3s are those with a dark triangle. And the mean recession for the cases that are reported was 3.4 millimeters in length. On the average per tooth, it was 22 minutes, 22.5 minutes, 0.3 minutes, and because the patient response was very positive. So this is the article that was published in the International Journal of Periodontics and Restorative Dentistry. It is one of the top 3 journals in the world as far as periodontics is concerned. So it took me about 2 years to get it published. The seminal case was this one here. The publisher decided to use this case, and when it was published, it was looked like this, and it was 3 years, just upwards. You see how there was no attached tissue. Can you see the arrow? You can't see the arrow. No, so you can see the upper left cuspid, number 11, how we have gained tissue. We have gained about 4 or 5 millimeters of a widened zone of attached gingiva. So we're pretty confident of root coverage, but we never say that that's our goal. We're not going to be judged by the position of the gum line. We'll tell the patient we're here to improve the thickness, the width and thickness of the gingiva of the gums that surrounds the teeth. That's our goal, to protect and improve the prognosis of the teeth. So the first study showed that after about 33 months, the root coverage was 81.2%. In other words, all the teeth counted together, 81.2% have complete full root coverage. That's a very good percentage for teeth which were class 1, class 2. For abbreviation's sake, I'm going to say that those are class 1, class 2s. So if you don't see a dark triangle, then there's an 80% chance of getting full coverage over time, not just right away, but over time you get the 81.2. Now, when there's a dark triangle, then the percentage goes down to about 40% or less. So we don't tell the patient who's gone into proximal bone loss and loss of papilla that we're there to have any hopes of getting better root coverage. However, if there's lacking attached tissue, then pinhole would definitely be very helpful. In what way would it be helpful? I want you to look at down below here, the last 2 lines. Follow-up keratinized tissue KT and KT gain. So we started with 0.8 average KT. And we follow up. On the follow-up, we had 3. So if you subtract 8 from 3, you get approximately 1.4, 1.3, 2.4, 2.3. So actually, there was a computational error in this particular study that was not caught. But anyway, it certainly was published anyway. But I want you to see that actually we gained quite a bit of tissue, keratinized tissue. So we can honestly, confidently say that pinhole will very likely increase the zone of attached gingiva. So now we have a 14-year study. The same group of patients were followed for 14.5 years. These are wonderful patients that come in every 3 months. Some of them dropped out, but most of them stayed. And so we had a 14.5-year study that was published online last year. But this month you'll be in print. You'll be published in print, and this is what shows. All right, now I'll point something very interesting. After 14.5 years, we still have 77.9 or still 78% of the teeth which had full root coverage after 14.5 years. 80% of the teeth treated still have full coverage. So after 14.5 years, that's not a bad stat. All right. But what's really interesting, I really want to emphasize this, the KT, the keratinized tissue measured at 14.5 years is actually higher or thicker in measurement than the 3-year study. So remember the 3-year study. Oh, what did I do? Oh, by the way, I want to introduce Jean. Where's Jean? I'll introduce Winnie in the back, and she's my chairside assistant. I want to introduce Andrew over there. These are my technical support. I really appreciate what they do, and I could not do all this without them. So now, 14.5 years. This is very, very interesting. We're very proud of this particular study. Took a long time, of course, to come up with a study like this, but it just wasn't needed. So then CRC, complete root coverage, I said, was 78%. KT, after 14.5 years, is 3.3. So what was 2.2 before, or down below, if you subtract 8 from 3, you should actually get 2.3, right? So at 14 years, or at 3 years, it was 3.3, was 2.3. At 14.5 years is 3.3. So the thickening of the keratinoid tissue happened, and to a significant degree is actually about 30% thicker in length and thickness than it was at 3 years. So we're very confident. This is why I'm so confident that when we tell the patient that you will get a widened zone of attached gingiva that would enhance the prognosis of your teeth, we're in very sound grounds. I hear some noise in the background. Do you have a question? You have any questions, please feel free to bring it up. Okay, so the same case now.
There's a
The 33
question.
Question, yes.
Yeah. May I know what kind of membrane are you using?
A membrane, I've been using a porcine non-cross-link membrane. It's called BioGuide, made by Geislich. I've used that for all my studies. I don't insist that doctors use BioGuide. You can use other membranes with success, but I found that BioGuide is easier to use in the beginning, especially. I use different kinds of membranes all the time. But for these studies, they use BioGuide. So I can recommend with high confidence that if you use BioGuide, you have the best chance of getting the results that I got. But membrane-wise, generally I would advise using non-cross-link membrane. In other words, we don't want chemicals in there. We don't need chemicals in the membrane because it will just produce more inflammation. We're not trying to get membranes that will last in the extraoral environment where you're trying to cover up a socket. So for our use, we'd rather have something that's non-chemicalized. And this is something that we use a lot. Okay. And they're the ones, this study here, this study was independently done, but Geislich has been instrumental in another study I'll tell you about that was quite interesting. So, but anyway, I'm glad you asked that question. If you have any other questions, please feel free to let me know. So this 18 years. And we
I have another
thicker-
question.
Sure.
Sorry for, thank you for the first one. The second one is, may I put the bioglass, like a kind of a stick on the bone, put in the papilla area to enhance the papilla height? Is that possible through pinhole technique?
Yeah, you can use bone to put in there, but the bone that I can get generally are very, very loose, and they kind of spread all over the place. So I have not been able to find a bone that you can stick in there, and it stays in a controlled way. So, but I'm working on it. But if you want to try to put some kind of a thicker type of a material that's made from bone, you can certainly try. But I found it too grainy. It doesn't quite go into the crevices. So, and then you have bone that goes all over the place. We don't have a socket where you can put the bone in. We have a wide area. So where do you put the bone? You can put the bone under the papilla, sometimes, but generally I found it too grainy and not controllable enough. So I'm working on some projects that will allow us to be able to use bone. So I think that's a wonderful question. Thank you very much.
Dr. Chow,
Yes.
so do you think, this idea just come up to me. Do you think we can put a tag, right? Long tag, like 5 mm tag?
Tissue tag?
Tissue tag.
Yeah, tissue tags doesn't
so
work very well. It does
to
not.
outside, put it outside.
Yeah, I know.
of the
I've tried that.
mucosa.
It does not enhance what I have. So you see, what I have already, I have plenty of stability with the collagen. We don't need to
Right,
pull it
right.
some more.
So for collagen, yeah, you don't need any, but if you want to put a bone, can we just continuing with her idea? So put a bone underneath, but you said that nothing can secure the bone, so can we put a tag?
Yeah,
over
but
that,
yeah.
mucosa?
I've tried using different bone, but if the bone does not hold the tissue there, so if you put a tissue tag does not hold for the amount of time it needs. In other words, besides the fact that the bone spreads all over the place, you don't get that full support of the flap. And then if you just use tissue tags to stick it on the outside, and then the tissue tag pretty much goes away. And it just drops off after a few days, a week or two, and then the tissue just collapses. Now, there is a technique called Vista. They actually put composites on the teeth. And then they use sutures to pull it down, and then they anchor it on the composites. So that's a different technique altogether. So the different techniques using tags, but tissue tags without a composite, without something to anchor that tissue, and something that can go inside, that can support it, I've not found it to be doable. So I've tried. I'm a researcher. I try everything. So I'm just sharing with you my experience. But once you learn the pinhole surgical technique, I encourage you to try different things. Maybe the way you do it can work. I would love to see it. So I'm all for using that technique, but you need to start with the collagen first. Learn the technique, learn how to release the tissue, the way it should be released, and learn how collagen can stabilize your flap, and learn what it can do, what that technique can do, and then you can see in what way you can improve the results. And in what way you can actually save time. I don't know. Maybe bone will work, but the bone that I have been able to get hold of cannot be used in a way that can stabilize the flap. But I'm all for new things. So if you have a new idea, a new membrane, and kind of a bone material that we can look at, that's FDA approved, I'd love to see it. So I'm all for new ideas, and I learn all the time. Every course I give, I always learn something, many things new from the doctors that I interact with. So we're open to ideas in the pinhole community. We have 4,000 dentists, 1,000 of which are periodontists. We share our knowledge all the time on our websites, on our exclusive doctors forum. So we love ideas, we love different things that we can share. So we show cases that we do differently, show cases that succeeds, show cases that failed, and then we're always in constant contact. So I love these ideas. That's a wonderful thought, using a tissue tags, but maybe there's a tissue tag that we can use. But anyway, back to this one here. Any other questions?
Thank you a lot, Dr. I think really good. We heard this one before, but this is the first time I listened to your presentation. That's great. I just wonder, if you put, I know you do a lot of research for your test. I just want to know the result. If you put still get some fresh tissue from palate, go inside through the hole, pack that can improve the result or not?
Yeah, well, I will tell you that that's a very good question, by the way. What if you put a graft material there? Okay, so with this technique, I've not used a tissue from the palate, because now once you have the tissue, how do you get it to go under the papilla and stay there? Because it'd be like a goldfish. So with this technique, it's hard to use a soft tissue like that. However, in the same article that I talked about the pinhole technique using collagen membrane, the same article also talked about using an allograft, alloderm. I actually use several cases. I use alloderm. So what I had to do was take a piece of alloderm, I put collagen, I put one suture each on each end. Then I thread the tissue through the pinhole and tied it around the root. Then I pull the alloderm specimen around and tied it with the suture, and then that worked. So the results of using the alloderm was the same as the results using the collagen. However, using alloderm took a lot of time and very complicated, but it's definitely doable, and the results are the same. So I would postulate that we use a graft specimen from the palate and use the technique that I described in my article, that you get results probably just as good as collagen. But that's a great question. I know that with those questions, you're really with me on this. Now, this is a very interesting study. This is a randomized, a split mouth randomized clinical trial comparing pinhole with grafting. So pinhole was done on one side of the patient, and grafting was done on the other side. We actually this was done at the School of Dentistry at the University of Buffalo. So at the dental school, the postgraduate department sponsored this, and the actual commercial sponsor was Geishling, and they must have invested about at least $300,000-$400,000 in their study. So this is a real highly high academically approved standard of research. So we find patients with similar recessions on both sides. By the flip of a coin, it's decided which one to do first, whether it's pinhole or grafting. And then we kept track of the patient. We started with over 40 patients that we did that on. And then it was going to be a long-term study, but COVID came and cut it short. So we presented 12-month studies. So it showed that, we were able to show that both techniques got the same clinical results. Okay, so this is very interesting. The split mouth is nothing more academic, more clinically valid than use a split mouth study comparing two techniques. So the left is the grafting technique, the subepithelial connective tissue graft using graft tissue from the donor tissue from the palate. You see before on the left-hand side, and the figure 2 on the left-hand side 1 year later. This is very thick tissue, very healthy tissue, and that tissue is there to stay, no matter what. You can be very confident of that tissue because it's so obviously much thicker in terms of its horizontal measuring length. So now look at the picture on the right. This is pinhole. Pinhole basically accomplished the same thing. However, at 1 year, it accomplished the same thing, but it looks less thick. So you can say that the tissue match is very desirable if that's an issue with the patient. If the tissue match is not important, then the grafting technique is the same. Now, interestingly enough, because of the skillfulness of the surgeon who is still the chairman of the periodontics department, pain-wise, patient didn't feel any difference, pinhole or grafting. So we don't have a difference in terms of results, except that now you notice also the width is approximately, it was about the same. Pinhole actually had a little bit more tissue, vertically speaking, so it was wider that way. So now the it's not on my slide, but in terms of the time, it was 22 minutes per tooth, or 20 minutes per tooth. Now for the grafting, it was something like 45 minutes. So the time is the advantage, is a unique advantage the pinhole offers in a case like this. Then there was a radiological study that showed, I won't go through too much of that, that 96% of the before and after CBCT shows that there is no loss of bone. There's actually a slight gain of bone after 2 or 3 years. So one more study, and then I'll let you ask questions. Now, we are GPs, so we're going to be doing pinhole, and we're going to be doing cosmetic dentistry. So what right now, don't look at the right side, look at the left side of your screen. If somebody walks into you today and say, "Doctor, I want you to fix me. I want you to do the best you can in terms of creating a better gum line and give me something that's cosmetically pleasing to me. What can you do for me?" So right now, imagine what you would do. If you don't know pinhole, what would you do? You will send it, and you can do grafting. If you're trained to do grafting, you can do grafting. So you have to do how many grafts? You can only harvest so much tissue here, right? So you have to do it maybe 3, maybe 4 times. You have to wait 3 or 4 months, maybe 6 months between each one. It will take you a long time to do this. So there's a disadvantage there. Now you can, if you don't know how to do grafting, you send it to a specialist who can do this for you and with the same result. Now with grafting, some of you have done that already. I'm sure I've done that. I've sent the patient to a specialist, and it comes back, the gum line is not necessarily even, because with grafting you don't necessarily get that get the symmetry. With pinhole, now if you're training pinhole, you have a choice. This is published by the Journal of Cosmetic Dentistry in March 2024, where I did this case. I did the interior veneers and lower crowns and veneers and the pinhole all the same time. I prep and did the pinhole the same day. You can do that. So with pinhole, you can actually do a combination of the two. If you are a cosmetic dentist and you have pinhole, you don't have to do pinhole, wait 6 months, and then do the veneers. You can do otherwise. What would you, if you try to do the veneers first? Where would you put the margins? So you have to treat the gum line first. And so if you know pinhole, you can have 2 choices. You can do the pinhole surgical technique and wait 6 months, and then do the cosmetic dentistry. Or, excitingly enough, you can do both at the same time. So this is a little bit advanced, and this is how we teach at the advanced courses how to do things like this. Okay, so I trimmed this kind of a procedure called crown shortening. So now dental literature has a new term called crown shortening. So this is the before, this is the after. Before on the upper left, 35 months later on the lower right. Okay, real quickly, why it works, because it's minimally invasive. We use guided tissue regeneration principles, just like the one you saw. And the collagen is the barrier, prevents the epithelial cells from getting to the bone, and let connective tissue grow into the bone. Now, some of you might ask, why does it work? Why don't you need to have tissue tags? Why don't you have to use sutures? Because there are these circular fibers, in addition to other fibers, that compose the the structure of the collagen of the gingiva. So when you stretch it, and then you put a lot of collagen in there, and then it causes the tightness of the constriction of the circular fibers in the gingiva explains why pinhole works in the mouth. And then another reason it works in the mouth is the masseter actually pulls the flap downward on the uppers and pulls upward on the lowers. The buccinators actually pulls the flap downward and forward, both upper and lower jaw. So the muscular attachment is also a something that explains why we have what we have. So that's all I have for you guys. Unless I'm ready to answer any questions you have. Unless you want to see some more surgeries.
I have one question, Dr. Chao.
Yes, sure.
It's such an honor to have you here give us a presentation. Finally,
Thank
nice
you.
to meet you.
It's a pleasure. Nice meeting you. I hope to see you. I hope to see you again at one of our courses.
My name's Hong Yu. I have a question, a technical question.
Sure.
When you release the tissue apically, incisally, do you break the connective junction on the facial or buccal, or because there's like 2 to 3 millimeters tight junction at the epithelium junction. Do you break that, or you leave a tiny bit? You know what I'm saying?
I'm not sure I understood your question.
Okay,
So
around the sulcus.
around the
there
sulcus. Oh
is-
yeah, okay. All right. All right. So there's total detachment of the marginal tissue from the root. Do you see this here? Now you see that on the upper picture. Is this better?
Yeah.
Now you see this tissue here? There's no attachment at all because it moved from here to here. It was attached, you could not move it. So my instrument can come in here and I can poke the instrument right through here. This instrument here can actually.
So the tissue on the facial of the tooth is completely detached. There is
Detached,
like
yes. Absolutely.
Okay, yes.
Completely detached.
Okay.
Unless you detach it, you cannot move it that far.
Okay.
You see what I mean?
Uh-huh.
So the tissue in my class one night, we do a full upper surgery in the morning, and then a full lower surgery in the afternoon, and we can show you how the instrument actually will go and from underneath the pinhole go through and come. You can actually see the instrument on the facial of the flap. You actually poke through, so there's no attachment at all. Everything is totally loosed. There's no attachment whatsoever to the root, to the alveolar bone, to anything lateral or apical. The only connection is the soft tissue on the buccal and its attachment to the lingual papilla. So it's totally, yeah. This whole thing is completely loosened up from the bone and from any attachment at all. And that's the secret of pinhole. That the technique is in how I can show you how you can actually get that total release, which is what you see here. Everything release so that basically it's at the gum line, it's at where it is already. All we have to do is stabilize it with the collagen. We don't have to push it. Basically, the collagen goes in and holds the tissue in place. Let's show another case.
Thank you.
Yeah, that's a great question. So you can see how unless you detach the tissue from the connection to the roots, you cannot move it up that far. What do you move it? Why is it not? Okay, we have a lot of instructions, of course, and we do have swelling afterwards, but we have pain level is about 1 to 3 out of 10. We don't have a downtime problem if you have swelling, and then the swelling will be about a week or 2. It slowly goes down, probably by about the 3rd or the 5th day, you go down, generally speaking. So patients don't have to have any downtime because there's no pain. There's hardly ever any bleeding problems. We have very little post-op problems. Patient can use a face mask and he or she can go to work. So this patient, you know, you don't want to put pressure on it. You don't want to lick it. You don't want to put your lip on it, put your finger on it. So we have a lot of instructions as to what to do and what not to do. And this is the etiology, it's basically bacterial, anatomical, and we do go into different treatment for bruxism. And you have your own favorite treatment for bruxism, but I do have a recommendation as to how to treat this problem prior to the pinhole surgery. So when you do a pinhole case, you look at the bacterial problem, you look at the bruxism problem, and possibly once in a while, TMJ problems. You must treat that first because this is what causes it. The secret to the long-term results that I had is that I do the basic work first on the patients. And then so you have a lot of work to do before the surgery, a lot of work to do after surgery. So I just want to conclude my presentation by telling you that that actually you can combine this procedure with the orthodontics. You know how you would present you would present an orthodontic case, then but you have recession. So what do? Do you treat the recession first, or do you treat the ortho first? And most of the cases, not every case, most of the cases you can do both at the same time. It's a one treatment plan. You do pinhole, you stabilize your teeth with a inactive retainer. Then you do the pinhole, and then you wait 3 or 4 months. Then you start the movement with the orthodontics. So the patient gets one treatment plan taking care of both problems with the orthodontics. So orthodontically, you can incorporate pinhole with your orthodontic practice. You can incorporate it with your crown bridge practice, your cosmetic practice, as well as your endodontic, your orthodontic practice. So that's a very important modality you want to consider when you think about orthodontics and pinhole surgical technique. So how many times do you see recession even during orthodontic treatment? So that's something you can intervene with pinhole at the time. And then you can do it before. If something develops after pinhole, after orthodontics, then you can use pinhole also. So those are the 2 applications and that I want to talk about. We also, in our advanced courses, we talk about how to use pinhole and get primary closure to your implants without a scalpel, and get wonderful tissue response and get a wonderful cosmetic results if you do the front teeth. So that's the end of my presentation. And we want to basically let you know that for your class, if you're interested in taking the course, we have a very special for you, Jean. So would
I
you
have
go ahead?
one more question, Dr. Chang.
Yes, go ahead.
When you do whole mouth treatment or quadrant treatment, do you notice any difference? Like, is it better to do 3 smaller area, like 3, 4 teeth one time? Or it doesn't make a difference if you do a full mouth or full arch?
That's a wonderful question. That's a wonderful question. That's one of the points I want to really, really emphasize. Pinhole, if you compare pinhole, if you have 2 or 3 teeth, pinhole, you still have to basically release the tissue from the molar all the way to the central. Let's say if you have let's say recession at the cuspid and the bicuspid, then you have to go 3 teeth to the mesial and 3T to the distal to get the release that you need. So to answer your question, is it better if you have a choice? If you have recession here, here, and here, it's a much better choice to do the full arch. It's much easier in terms of your time and the patient's time and cost effectiveness. There's no match. You can do because of you spend so much less time in doing that procedure compared to grafting. You are able to be very cost effective in terms of saving the patient a lot of money and saving yourself a lot of time and create a result that will be very pleasing and very pleasing to the patients, including very little downtime and very little post-op symptoms. So definitely, I encourage my colleagues who have taken the course to, if there's a reason to extend the incision, extend the release wider, and then you'll be better. You actually save a lot more time than if you do a full arch. They would do it in quadrants. So if there's a choice, I would say do full arch. If there's no choice, you do a quadrant, of course. You have only 2 or 3 sessions over here, and then you have none others, then you do a quadrant. But the secret with pinhole is coming down to one word: release. If you get the release, you'll get the results. Everything else is technical. So yes, do full arch, double arch, even more cost effective and very productive for the office.
Thank you.
Your patients will love you. It's wonderful to show
Dr.
the
Chow,
patient.
Dr. Chow, I just sent Zhang the picture of before and day 1 of this.
Would you show that, please?
And it's also for my full arch for a long time, my first case. So please give us a comment.
Sure. Okay, give us a minute. We have shown right now the slide shows that for your class, we have a special offer for the online course, and for the online plus 1-day course, and for the 1-day training course, 1-day advanced and the advanced training. So we have the different numbers up here. So if your class is any member of your class wants to take our course, would you put the dates? Are the dates available? We have the courses coming up in.
Yeah, thank you so much, Dr. Chow.
September 25 and November 13. We have 2 courses coming up where we can actually give you in-person training plus advanced training all the same weekend. Okay, are the pictures coming up? So I would say that for large cases, you have so much more leeway in terms of charging on the sliding scale, because your time, the time you invest in the procedure is so much less than what would be if the patient had to go out there and get grafting done. So from a practice management point of view, pinhole has a lot of benefits to the patient.
This is after.
We can put it on the slide. Put this on the slide. That was before. There's no before here.
Yeah, before.
Yeah,
Okay, we're printing it,
Feedback.
and it will take a long time to put it together. It's hang on. But just give me one picture of the before. It's coming. Thank you for reading. Let's do the after. We're printing the before. We have the afters, which looks great. It's very nice.
Mhm. Thank you.
Very nice. This is great.
Next one is.
We're just not getting the before. Okay, so this is the before. Could you put it?
Mhm.
Yeah.
Okay, this is the before,
Mhm.
and this is the after. Okay, now you put the after. That's terrific. You have wonderful
Mhm.
overcorrection. And you have severe recession before that. Severe recession.
Mhm.
Now put the after again.
Mhm.
You did a wonderful case.
Mhm.
That's the kind of case I'd like to see. You did very good.
Thank you, Dr. Zhang.
Yeah, this is
For your
like
comment.
magic to your patients when it's up here, and then when you leave it's down here.
Yeah.
So that's so now tell me, was there much post-op symptoms, pain, swelling, bleeding?
Yeah, this morning the patient come back, it feel pretty good.
Yeah,
And the thing is, we didn't, we are going to deliver the tree for brushing. Maybe next couple of days, we didn't prepare that. So we ask patient, be careful to not brush the
Yeah.
tooth there.
yeah, they do this, and they
Oh,
push
don't
the
do
collagen
that.
out. It happens all the time. There's no consequence to that, but we don't want them to do it all the time. I tell the patients the collagen under your gums is like toothpaste. It doesn't come out
Uh-huh.
unless you do this, unless you press on it. So something we really emphasize when we train. When you see a patient, really have to tell them
So
the day.
Dr. Chao, you mean you do, let's say, do this, right? No, don't do this.
Yeah. There are a lot of do's and don'ts. We'll give you the instructions. We emphasize post-op compliance. We have a sheet that we print out that the patient actually will stick to the
Okay.
mirror. It has a suction cup.
Yeah, I think I don't remember I have that. Maybe
Yeah,
we ask the team send this one to the Dr. Chi's office.
Yeah,
Uh,
we'll
to
send you
the
some.
patient.
No problem. We'll
Yeah.
send you some, and patient can read it every day. And then when the
Okay.
patient comes back, we actually put disclosing tablets. We put a disclosing solution to make sure that the gums look dirty.
Okay.
If it looks black, if it looks purple and blue and doesn't look good, we're very happy.
Mhm.
So patients have to be reminded all the time, don't touch it, don't lick it, don't brush it, don't press your lips against it. And we have wonderful results, short-term and long-term.
Mhm. Okay. Thank you, Dr. Chao. Thank you for your time. This our group special webinar. Yeah.
Okay, I know this is for super general
GP.
practitioners. Adding pinhole
Yeah.
would be a wonderful addition. You can also integrate this into your implant practice in many very useful ways. So in our advanced courses, we'll be talking about that. So I hope to see some of you, if not all of you, at one of the 2 seminars coming up.
Yeah, we will.
Question?
Okay, Dr. Chao, thank you.
Thank you.
Goodbye.
Bye-bye.
Okay.